name is Leanne from ArcPoint, and we're really excited to be here and have Serum Tears for Dry Eye webinar for all of our participants. Dr. Matthew Ward is going to be our special guest today. Really happy for him to be presenting this really important webinar for you guys to learn a little bit more about prescribing Serum Tears for dry eye as a dry eye solution. Dr. Ward, I'd like to turn it over to you very quickly. If you can introduce yourself, give us that 2 or 3 minute resume background, and then you can go ahead and launch into your presentation. We have the chat as well as the Q&A at the bottom of everybody's screen. So as you are listening to the presentation, if anything comes up, please put your questions in those 2 chat boxes, and we will try and get to those throughout the course of the webinar. And if not, we'll tackle them at the very end. Dr. Ward?
Thank you. Thank you, Leanne. It's great to be here with all of you. And I won't bore you with a full 3-minute CV recitation. It's just great. I really appreciate you taking some time. Some of you probably just finished your clinics and are eager to get home. So I'm a full-time clinician, cornea specialist, practice at the Riverwoods Eye Center in Provo, Utah. I did my medical degree at University of Utah, and followed that with ophthalmology and residency and cornea fellowship at the University of Iowa in Iowa City. And really have been excited about these new technologies that allowed me to use Serum Tears more effectively and frequently in my clinic, and I'm excited to share that with you, which has really been enabled by ArcPoint and Aseptikits. So the title is Serum Tears for Dry Eye, the time is now, and ArcPoint and Aseptikits is how. So as we all know, dry eye disease has really evolved. Our understanding of it and our definition of it has evolved over the last several years. Kind of the fundamental definition being a multifactorial loss of ocular surface homeostasis that results in inflammation. So homeostasis, as we know, is this balance that our bodies like to remain in, and there's active processes happening all the time to try and maintain this. And when we're out of balance, there's symptoms and problems. So just starting with an example from my clinic, this is from last year. Judy is a 47-year-old woman who came in, had seen multiple clinicians. This was sort of a tertiary type referral, had poorly controlled diabetes, an undefined autoimmune disease, a lot of pain and light sensitivity, but her main issue was just vision. She couldn't function at work, and she was legally blind in my clinic in both eyes. Her cornea looked something like the picture on the right, which might be mistaken for the surface of Io, one of Jupiter's moons. So going into her history, she'd tried Restasis. In her own words, she just said that burned the crap out of my eyes and was too expensive. So in this sort of more significant advanced stage of dry eye disease with multiple causes, I decided, let's temporize this, let's calm this down with amniotic membrane graft, which I don't use a lot in dry eye, but in some of these recalcitrant cases I do, more as a temporizing measure. But I feel like it's really important to follow it up with something. And what are you going to follow it up with when they've tried just about everything? Well, Serum Tears are a great way to get relief that is maybe short-lived from the amniotic membrane, more long-term. So we started her on that. She came back a month later. The amniotic membrane only lasts about a week, and then she was already seeing 20/30 and functioning at work. She was ecstatic. So this was not just helping her with discomfort and pain, but it actually changed her life by improving her vision in a significant way. So the DEWS-2 study, published, I believe, in 2017, is kind of the Bible for dry eye disease diagnosis and management, and it goes through in a lot of detail. I just want to highlight the way that they recommend we manage dry eye disease, beginning in stage 1, which is really the majority of patients. Stage 1 is when we manage patients in stage 1 disease. These are usually OTC, or over-the-counter therapies, omega-3 supplementation, sometimes some lipid-based artificial tears, hot compresses. And a lot of patients do just fine with these. They're okay and are happy to remain on these simple treatments. Stage 2 is what I would call the majority of dry disease specific clinic visits. So patients that are specifically scheduling an appointment to see you because their eyes are hurting or burning, or maybe some other visual consequence of dry eye. Often in these situations, we may switch to, and this is where DEWS recommends that we switch to preservative-free artificial tears if not already on them. Considering punctal occlusion, pharmacotherapy is recommended by the DEWS too at this stage, considering Restasis or Xiidra, the two primary commercially available formulations. There's now others that target meibomian gland dysfunction and others as well, and steroids are often started at this point. Eyelid disease is really important to treat as well, the meibomian gland dysfunction, possibly Demodex. So we often put people on orals like doxycycline, azithromycin, or maybe tea tree oil if they've got significant Demodex. Stage 3 management recommendations are where it's considered, a significant escalation. And this is the point at which the DEWS to recommend serum tears, therapeutic contact lenses, perhaps neurostimulation of lacrimation, or direct via cranial nerve 7 activation. So there's some technologies that can do that now, or pharmacologic using a cholinergic agonist such as Trevia. So these are some more advanced therapies. And then stage 4 would be sort of really, really severe disease where they may need long-term topical steroids, considering amniotic membrane graft, cauterization of the puncta, and perhaps even tarsorrhaphy in very severe cases. So really one of the messages I want to drive home is that we should be rethinking the DEWS recommendations, especially at stage 2. In my opinion, serum, now that we have the ability to obtain it so simply and effectively, it should be considered at stage 2. Yes, the preservative-free artificial tears, punctal occlusion, all the others, but also consider serum tears earlier. There's no reason not to. There's kind of an old thinking with serum tears that procurement of them is challenging. It's expensive. For a long time, eye banks were some of the only people that would do this. I used my eye bank here in Utah for this for many years, and it was a little bit cumbersome. They were great to do it, and I appreciated their help, but it was hard for patients and expensive. There's some that may question evidence for serum tears and consider it reserved only for the advanced pathology and severe recalcitrant cases, the DEWS stage 3, as I mentioned, or like an ace in the hole when you've tried everything else. So really what's important is to think of serum tears as, something that we can start earlier and have much more effective results than some of the other stage 2 therapies. Versus Restasis and Xiidra, serum tears are natural and safe. They're more effective. And I'll present some data about that. They're better tolerated and they're much less expensive in most cases. So, a lot of our patients are used to natural therapies. Serum is often used in dermatology and other specialties for treatment. And so serum or PRP and things are they're normal, that it's now more normal for them to think of them as therapeutic. We're kind of in a free range, organic, locally sourced society, and that's kind of where these fall. There's a huge unmet need to treat dry eye, and this is a slide that shows how significant that is. There's only 16 million, it's still a big number, but 16 million in our country that have a diagnosis of dry eye. About half of that are actually using prescription eye drops for dry eye. But go over to the far right, you can see there's artificial tear use is almost 120 million people. So it's just this giant number of people that are self-medicating, maybe not fully effectively being treated. And so this is just a giant market and a lot of unmet need. Restasis, a huge product for AbbVie. This is cyclosporin 0.05%, generated $1.3 billion in sales in 2021. And without insurance, which some of the coverage is spotty, it's about $4,000 for 6 months of treatment. There's now generic available that's compounded by 503B. That's $1,200 for 6 months supply. Xiidra, lifitegrast 5%, heavily marketed. You see these ads on TV everywhere. Almost $500 million in sales in 2022. Also very expensive, about $4,000 for 6 months, and there's no generic for this at this point. how many actually use these medications? There's a 2019 real-world data study that showed, it was a huge study, large numbers of both Restasis and Xiidra patients. It showed that the adherence rate, which is doses taken versus doses prescribed by their doctor, Restasis was about 6% adherence rate. Xiidra was about 10%. The main reason for cessation was, like my patient Judy, pain for Restasis. And why did most people stop Xiidra? There's taste ulceration or dysgeusia. How many discontinued Restasis or Xiidra? The rate of discontinuation, not just poor adherence to prescribed regimen, but the rate of total discontinuation was over 70% of cyclosporin and almost the same in lifitegrast. And interestingly, the median time to discontinuation basically totally matches what they usually get as a free supply to start, their trial from their doctor. So about 90 days, a 3-month supply with Restasis, and about a month with lifitegrast. So there's really not a lot of motivated patients to stay on these. There's some. I have patients that are on them long term and do well, and it helps people, but I would say the vast majority, it's not helping, and they still have unmet need. So there's a huge unmet market here. Patients are currently not getting what they need. This is an interesting study, not a large study, but in 2022, a group compared serum tear therapy to Restasis in a well-defined Sjogren's dry cohort. It's typically a more severe symptomatic group, and they randomized them to receive serum tears or Restasis for 3 months. And then they used the original Allergan designed OSDI score, which was designed to obtain FDA approval for cyclosporin. So basically, by their own measure, the study was being, the main outcome measure was the company's outcome measure for approving the Restasis. And so the OSDI scores were shown to be significantly better in the serum tear group after this 3-month time point, which I thought was interesting. So there's at least one small study showing increased effect of serum tears versus Restasis, and that's been my own observation in treating my own patients. So what can these commercial preparations do that serum tears cannot? The answer is nothing. There really is nothing. And if you have experience prescribing commercial dry eye medication, and this includes the new ones for meibomian gland dysfunction, it is a pain in the neck. I'm frankly sick of it, because my staff, my practice, we're squeezed in so many different ways, and we expend incredible amounts of energy, staff time, sending in pre-authorizations for these medications, fielding phone calls from patients, often unhappy when they get to the pharmacy. They were told it would be so much with a copay card or something, and then they get a multiple $100 surprise when they go to pick these up at the pharmacy. And it takes a lot of our time, takes a lot of their time, and then they don't use it anyway. So that's kind of what's happening. But obviously, they're still selling a lot of it, enough of it to generate significant sales. So serum tears can do a lot that Restasis cannot do, and Xiidra. They're more comfortable, they're less expensive, and they're more immediate. And it can take quite a bit of time for Restasis and Xiidra to become effective, whereas in my experience, serum tears often offer a significant relief quite quickly. So the question we should all be asking ourselves is why put patients through an expensive trial of a pharmacologic therapy they're highly likely to abandon when they could have more effective natural treatment that provides relief now? And so, we've kind of become the lackeys of large pharmaceutical companies and doing their work for them, when we could be offering our patients a better therapy less expensively for much less hassle. So there's a huge opportunity for serum tears to fill this void. But as I mentioned, serum tears have a track record of being challenging to procure. So how do we go from walk that high line, like this guy in Moab, walk the high line to get to where serum tears become something that we're comfortable prescribing regularly and earlier in our practice for patients? What can we do to bridge the gap and increased utilization of serum tears? So the answer is ArcPoint Labs and Aseptikits. This is a great partnership that's now been going for about 3 to 4 years. Well established. ArcPoint has many locations around the country. I believe just joined with another large lab group to offer even more options throughout the country. And Aseptikits, which is really the engine that drives this this new ability and this new way to apply serum tears in our practices. Aseptikits created what's basically a clean room in a bag. So it made it so there's no laminar flow hood needed to produce sterile preparations. These are USP 797. They meet the guidelines for 797, if not exceed them. And they basically can be used anytime, anywhere to prepare these. I don't have an Arc Point lab in my own area here, so my staff does the phlebotomy, and we make them here on site for our patients. But how can we bridge this gap? How can we help doctors and patients think differently about this? Well, it's important to know it's okay to start serum tears sooner and more readily than before. They don't have to be just this ace in the hole. It's okay to use for mild to moderate dry eye, not just complex indications. It's easy to procure and less expensive than pharmacotherapy. It's helpful to help patients understand it's natural. It's a natural treatment rather than a pharmaceutical treatment. And I can tell you that I've kind of made the switch where I almost never prescribe Restasis and Xiidra anymore. If patients come in and they really want to try it, or there's some other reason, then I still do. But I almost always recommend serum tears first. And I've been really amazed and surprised how straightforward it is. Patients get it. They want to do it. They see the value. They see how much less expensive it can be. And generally, they're very happy. And they come in again and again because it's a recurring thing that keeps patients coming into your practice as they refill their serum tears over the span of this chronic disease. People always ask about PRP, platelet-rich plasma. So this is plasma is serum plus coagulation factors, or the fibrinogen and the platelets are added there. There's two small studies that compare PRP to serum tears. They're very small, and they basically showed that the preparations contain the same growth factors. There's some variation in concentration of those growth factors. One concluded that PRP is non-inferior to serum. One showed that slightly better effect from PRP. So basically, currently with Aseptikits, and we hope to have a kit available to produce PRP as well. But currently, we don't really see that there's evidence to suggest one is better than the other. If someone doesn't do well on serum, perhaps trying PRP is a reasonable thing, and vice versa. But we don't believe it to be inferior. That's all I have for today. So we just have to make the jump and try using them more. I think you'll find that patients love it. Your staff enjoys it. It can build your practice. It can generate revenue for your practice that you didn't have before, and it's a good thing. So, any questions?
Thank you, Dr. Ward. Yeah, you can use the Q&A or the chat down at the bottom of your Zoom if you have any questions, or you can go ahead and raise your hand and I'll find your name and take you off mute so you can ask some questions as well.
Says there's one in the chat, but I'm looking down here, I don't see one.
Is there a good place to talk about how the kits work? Any tips and tricks that we should know about?
Yeah, so I would maybe refer you to Aseptikits website where there's good videos demonstrating how to use the kits. There's one of the cool things that they've come up with is there's a little ratchet tool that is inside the kit that allows you to cap the bottles. It was kind of funny, the first few weeks or months that we used the kit, I didn't really notice the ratchet tool. I don't know. I'm sure they told us about it, but we were just twisting all the caps on by hand, which is fine, but the ratchet tool makes that a lot easier. And so there's that aspect to it. But yeah, it's really quite straightforward. They've gone through a few iterations to allow you to put all 12 caps on at once if you're using the Paula 12, which is what we typically do. But there's also Paula 8 and you know, some other options.
Cool.
I would also add.
And if they have an opportunity to introduce Gail, who is the CEO of Aseptikits, maybe you can take a swing at that as well, Gail.
Thank you, Leanne. Yeah, in fact, I would encourage anyone wanting to know more about how the kits work to just contact Becky at sales@aseptikits.com or Jess, and they're more than happy to help answer any questions about how the kits are used or any detailed questions about them.
So I see a question here from Ryan Collier. Yeah, so what % do you typically start patients at for mild to medium dry eye? So generally, I try to give the patient as much volume, of the highest volume of tears they can get with one kit, with one blood draw. So I would say I'm usually not thinking so much as a percentage, but I'm basically trying to fill all 12 bottles at maximum concentration. That usually ends up being about 20% to 25%. And so that's a typical place that I'll start with. And I would say even for severe patients, I'm usually starting them at that %. But it does give you the ability that, and there's in the kit, it has an easy kind of rubric or flow chart that you can look at to know the volumes, to make the proper dilutions and things. So I will, if someone's not responding at 20%, I'll usually double it to 40. I think I've maybe gone up to 60 a few times. But obviously the higher the concentration, the fewer bottles they get for the price, and so the less they'll last for the patient. But sometimes it's they're willing to do that to get a little bit better effect. I don't know that there's a lot of data on titration of serum concentration, but I do feel like anecdotally there have been patients that have benefited from higher concentrations in some cases.
Thank you. Any other questions for either Gail or for Dr. Ward? Cool.
Well, good. Yeah.
Thank you. Yeah, thank everybody for coming. Really appreciate that. Again, we recorded this, so we will send that out at probably at the beginning of next week. So you have this to refer back to. Dr. Ward, any last things that you'd like to offer?
No, just great to be here with everyone. Hopefully that was helpful. And certainly they're welcome to email me or anything if they have other questions. I can put or you can send my email if that, I'm happy to do that. So
absolutely can do that. Excellent. Well, go have a great rest of your Thursday afternoon. We really appreciate everybody's attendance today, and have a great one.